So Lisa and I wanted to talk this morning a little bit about what are called EPAs. These before. This is new within maybe the last 15 years, the idea of EPAs. But this is really a way to provide not only evaluation based upon the things that we're doing every day as physicians and the observable activities with our trainees, but also provides a framework in which we can provide autonomy and really the idea of entrustment to our trainees. So the things that we're hoping to cover is just a brief overview of the changes that have happened in medical education and assessment, particularly as it relates to the competency-based model that we have used. And anyone who's participated in our clinical competency committee probably knows this very well. And then some of the challenges that come along with that and using that type of system, describing again what EPAs are and how we can use that to assess trainees, and then maybe most importantly, how we can provide a framework to evaluate entrustment and how that influences autonomy. So the traditional model of graduate medical education has been that by time alone, that just because you're doing residency training during those 3 years, you will, as a result of being in that training and seeing patients, meet the established objectives for that training program. There's obviously a lot more that goes into this. This is a bit of a flawed model, but the idea has always been that, well, just by doing this, you're going to absorb the information that you need to be a competent practicing pediatrician. So it's this idea of, you know what you need to do, and over the course of residency, you eventually are able to show and then do those things that would lead you to being a competent pediatrician. But we all know that there's a lot more that goes into that. And this is really what led to the development of competencies by the ACGME and what was ultimately the Milestones Project, to really try to describe the other factors and kind of in granular detail that go into the development of a physician over time. And so this is the whole idea that there are individual pieces of knowledge, skills, attitudes that you have to have as a physician, or in our case as a pediatrician, to be able to perform adequately upon graduating residency. And so the milestones and the core competencies developed by the ACGME were designed to evaluate these areas. But as Lisa's going to touch on, one of the flaws here is that it really relies on, you're directly evaluating the trainee, not necessarily the things that they're doing on a daily basis and the things that we all are observing in patient care. And so ultimately what the goal of this was to be able to describe and evaluate as a resident or a trainee is moving from a novice to, over the course of residency and then beyond, really that expert level of performance as a physician. Oops. I think Lisa's going to touch on competencies.
Yes. So as Nate alluded to, any of you who have participated in the CCC or the Clinical Competency Committee are very familiar with the 6 ACGME competencies and then their respective milestones. The competencies came about in the 1990s, so they've been around for a while. And then the Milestones Project rolled out about 7 or 8 years ago, and that assigns several different milestones to each competency. They have recently revised the milestones, so we have a new set of milestones that we'll start using in the fall. But as Nate also alluded to, there are a lot of challenges in taking the evaluation data or even our personal experience with a particular resident and being able to assign them to a milestone. The milestones are more descriptive, and rather than just saying a trainee is at level of training or above or below, like a traditional Likert scale, they do at least attempt for us to root a trainee in a particular behavior. And the other thing to mention about the milestones is they're really a lifelong continuum. So on a scale of 1 to 5, 5 would be hopefully achieved throughout your career. And we don't expect our residents to be at a level 5 to graduate. So yeah, some of the challenges are just that we may not observe a particular milestone in a trainee at any given time. And so then we're sort of guessing or making our best judgment about where they fall on that 1 to 5 spectrum. Some of the milestones are extremely difficult to assess, such as how does a trainee deal with ambiguity? That's really more of getting inside of someone's head, and we don't have good data to support where we would rate someone on that particular milestone. Some of the difficulties may be a little bit improved with our new set of milestones, but for all of you who've been on the CCC, know it's very difficult. It's a great idea, I think, in theory, but in practicality, we have a lot of challenges. So EPAs come in as a possible solution to the difficulties that we have with milestones, clustering milestones into different groups to describe specific behaviors and tasks that we want our residents to be able to perform by the time they're done here. And so really EPAs were introduced in 2005 to define better the work and the jobs that we do as physicians, and not so much assessing a person, but assessing their ability to do that specific job or task. And this is really just saying the same thing again, but clustering groups of milestones into EPAs, which describe what people do in real life. Like, what do pediatricians need to be able to do by the time they're finished with training?
So this slide looks very complicated, but what this is showing is really the whole idea behind EPAs, and that you can cluster together all these different milestones and competencies into kind of one packaged EPA. So in this example, this EPA X, so whatever performance activity that might be, within that activity, you could probably assess at least a couple competencies. So maybe an area of professionalism, maybe patient care. And then within each of those areas, there's going to be sub-competencies, which again, for those that have helped with the CCC, you know those probably inside and out. And then those milestones, those definable achievements that throughout residency, our residents will be hitting along the way. And so within that one activity, and activities that we're all familiar with, you know, for example, taking care of acute diagnoses in the hospital, or taking care of an acute patient issue in the clinic, things that we're all doing on a daily basis, we can evaluate or observe what a resident or a trainee is doing, and where on a scale of entrustment they might fall based upon their performance. So really what entrustment comes down to is that you're taking a pre-entrustable learner, so someone at the very beginning of their residency training, or even if you apply this to medical school, the start of their 3rd year, where maybe they're really not doing anything to act, and then advancing on to doing things like you would early on in residency, but with that direct supervision. And then as time goes on, that supervision becomes more distant, and ultimately you are reaching the point that our supervising or senior residents would, where you're then providing supervision to junior trainees, and ultimately you become a fully entrustable learner. And this is where really the goal of every trainee is by the end of residency, you're fully entrustable and you really are able to practice independently. And so this whole idea of EPAs is that by observing these things that our trainees are doing, we can advance them along the spectrum of entrustment and provide autonomy along the way to encourage and build those skills. So really the practical thing, because it's a lot of theory, but how do you apply this in the real world? You know, if you have a trainee that's working with you, what factors will influence entrustment, and really the idea of trusting the trainees you're working with, so that we can provide additional autonomy? And so there are many factors that play into this, and some of these might be common sense. Others are things that we probably know influence this decision, but being intentional about it, we think might help with increasing that autonomy that we can provide. So there's certainly factors related to the trainee that will influence this, their competence, observations that you've had in the past. Communication skills might all influence your decision to trust a trainee. There are things inherent to us as supervising faculty, that might also influence this. So, for example, our previous outcomes with this trainee, maybe we've worked with this person several times in the past. The subspecialty that we're in, I mean, sometimes just the context of what we're doing will influence the degree of entrustment that we can provide. The relationship. So again, this gets to that idea of if there's a trainee that you've worked with 3 or 4 times and over 2 years, you might have a really good sense of the degree of entrustment that can be provided based off of those previous experiences versus the new interns that are just starting and that we don't know quite well enough yet. And then the task. Depending on the complexity, the acuity of the task, the level of collaboration that might occur with that task, or the proximity of support that's needed to perform that task, all of those things will influence the amount of entrustment that can be provided. And then certainly any contextual things like time constraints, the emotional environment, all of those things may influence the decision to provide trust or entrustment to that trainee. But on a practical level, these are the things that I think we can reflect on as we're working with trainees throughout the year. And as we get to know some of our residents better and better as the year goes on, this naturally should evolve. And the idea of an EPA is really that by being intentional about reflecting on these things, we can hopefully provide more autonomy and entrustment as they move through their training and also show or demonstrate with those activities that they are competent in moving along that spectrum of independent practice. So the American Board of Pediatrics does have a list of 17 EPAs that were developed several years ago. This is an example of 7 of those EPAs, just to give you an idea of the types of things that the Board of Pediatrics is expecting from an EPA standpoint, our trainees to be doing upon graduation. There are subspecialty EPAs that if you go to the ABP's website, you can look at those subspecialty EPAs as well. What you might notice is that these are kind of broad. They're very broad strokes when it comes to the types of things that trainees should be doing. But these are all things that as general pediatricians or as pediatric subspecialists, there are many components of this that we might be able to observe on a daily basis working with trainees. If you look at each of these EPAs that the Board of Pediatrics puts out, it's about a 4-page document for each of these. And within that 4-page document, there is at the very top this supervision scale. So for each EPA, there's a scale of entrustment to provide context for that specific professional activity. So for this one, where this is EPA 4, managing patients with common diagnoses in clinic, ER, inpatient, at the very lowest end of that entrustment spectrum, this is someone who we would trust to just fully entrusted learner. They're now supervising others in the practice of this EPA. And the question might be, well, what types of things are we supposed to be observing with this EPA? And if you get into this document, there's a whole list of patient care activities that the ABP's really in good detail written about the types of things that a learner should be doing in this EPA. These EPAs are all then mapped back to the milestones and the competencies that Lisa talked about. And then they also map these all back to really the general pediatrics curriculum and the type of content that this EPA is tied back to from a curriculum standpoint. So this all is very complicated. And really, we think the practical application of this is being mindful of the types of things that our learners are doing with these professional activities and how that demonstration of their competency in these areas might allow us to be a little more directive about the autonomy and the entrustment that we can provide to trainees. There is a lot of work being done on EPAs, and at our program director conference every year there is a session and multiple posters about EPAs. There are programs that are really trying to move more towards an EPA-based assessment strategy, as opposed to just our milestones and competencies, just because we're all so much more familiar with these professional activities and represent more what a resident or a trainee should be doing by the time they graduate, as opposed to discrete milestones. So that is what we had. It's a lot of information to cram into 15 minutes, but we're happy to answer any questions here or outside of this about EPAs.
Thank you. It's such a complex topic, and yet it really is meant to encapsulate those behaviors that we think make you a good physician. And sometimes it can be hard for trainees to understand what piece of that they might not be doing yet. And I think that's where the milestones help us out. But then rolling it all back into the gestalt under the EPA, I think is more what we as practicing physicians feel like are the behaviors we're trying to teach them. So they're both important. It's a real challenge, I think, to get them on paper because they're hard to articulate. So thanks for making a complex topic visible for all of us today.